So I call upon Dr. Divya, Senior Vitreoretinal Surgeon at LF Hospital, Angamali. She'll be giving an overall idea about how to approach a patient with inherited retinal dystrophy.
So at the outset, I would like to thank Dr. Lekha and KSOS for having me here. So I'll just briefly give an outline and will not go to the specifics of it. That will be covered in the subsequent talks. So approach to inherited retinal dystrophies. So as we all know, when you think of inherited retinal degenerations or dystrophies, it is genetically and phenotypically, it is a heterogeneous group and that share a progressive, variable progressive loss of photoreceptor function and which eventually leads to vision loss. So even though it is inherited, we think in terms of like genetic, it may not be present right from birth, it can manifest later. And the other aspect of it is that need not everybody will be having a history, family history. Only 60% of them might be having a family history. So when you think in terms of IRDs, we think like in various disease classification, that is depending upon primarily which cell is affected. So it could be photoreceptor, it could be RPE, it could be a combination of this, it could be Muller cells, or eventually the choroid also might be affected. And you will get some clue depending from the history by the age of onset. When it is like too young, like infantile origin, then you think in terms of diseases like LCA, achromatopsia. Little later, it is like Stargardt's, or in adulthood, you can present like even adult onset retinitis pigmentosa, autosomal dominant retinitis pigmentosa, pattern dystrophy, etc. And by the clinical course, so some can be progressive, some may be stationary. So progressive like retinitis pigmentosa, again choroideremia, and the inheritance patterns although would be differ. Like the could be autosomal dominant, recessive, X-linked, mitochondrial, and some would be having syndromic association, and some would be purely ocular involvement. So main thing is that you have to identify that it is an IRD. Second is like when you identify, you need to think that whether it is purely ocular or whether there is any systemic association, that is syndromic. And second thing is that whether this could be a progressive one or whether it is non-progressive. Two important things you have to keep in mind. And many of times when you have these syndromic associations, so of late they can be, it was attributed to ciliopathies. That means like these cilias are cells which is present in almost every human cell. So many of this systemic, why these various organs are affected, so they looked into this. So there's a various syndromes where dystrophies are associated with other systemic manifestations like auditory, renal systems, cardiac involvement, cerebral and neurological involvement, skeletal anomalies. So there is a huge list of it. And so how do we approach these cases? So first we have to get an idea whether it is inherited. So from the history and the systemic, if you're thinking in terms of a syndromic, elicit from the history if there is any systemic involvement. And always ask about the family history. And then do you have to do a comprehensive ophthalmologic and systemic evaluation. So from the clinical history, when you ask the symptom profile, whether the patient has difficulty in night vision or a day vision problem, whether the peripheral field loss is there, color vision is affected, and what is the refractive status of the patient, whether the child had nystagmus or has nystagmus, and how much is his functional disability the child or the patient has. And when you think in terms of systemic, because you need to rule out whether it is a syndromic. So ask about the systemic history, like renal involvement, whether examine the general physique of the patient. So you pick up many of the anomalies. So don't get into the habit of looking directly into the retina or the eye. Just see how the patient walks into your OPD, what is the physique, whether the patient is obese. Then look at the fingers, toes, whether there is a polydactyly. Look for any neurological signs, any skeletal anomalies, and again try to screen the family members also, and take a proper birth history and a developmental history. So age of onset and the rate of progression from the history actually helps to gives you some clue regarding the IRD what you are dealing with. And now coming to the clinical examination, so first thing is that the visual acuity the child or patient has, then you see whether the patient has got any other of ocular involvement like cataract, any keratoconus, or any anterior segment anomalies. Then look at the fundus. So when the vision is poor or low, you have to explain why the vision is low from the anterior segment. Look at the fundus, whether any disc anomalies, whether macula is affected. if the field, look at the periphery, how the vessels are. So all these findings you should explain what the vision loss has caused. Then coming to investigation. So after your systemic examination, the ophthalmic examination, now you move on to the investigations to differentiate these entities. So always take a picture fundus photograph to document at least the progression and look the changes. And then look autofluorescence. It is a very good tool actually to pick up any progression, because that gives a broader view than an OCT which looks at specific areas. But the OCT will help to differentiate many entities, like whether the macula is involved, macula is spared, or any other abnormalities at the macula. Then visual fields, and then ERG is another test. So the details of it will be covered in the subsequent talks. Then another test is microperimeter, especially in the era where we think of genetic therapies and all. So ERG, especially in cases of like RP or chondrodystrophy, many of them it would be extinguished. So you think in terms of other investigations like microperimeter, full stimulus threshold, where the ERG is absent, still if some residual cells are functioning, it will be able to pick up. So these tests actually help to know whether the patient is eligible for gene therapy or what is the response to this therapy. So genetics, actually you will know what is the inheritance pattern, and if it is a carrier, then you will be able to pick it up. And in some diseases you want to know the prenatal screening also. So as I mentioned, it helps in diagnosis. The details will be covered in subsequent. Again, the talk is there. So to know, again, helps to know whether the systemic involvement is there, and we need to send the patient for any systemic evaluation. And also again, prognosis, the rate of progression, and then the feasibility for gene therapy and prenatal screening. So when do you ask for a prenatal screening? When there is a strong familial history of a very severe retinal dystrophy, or the dystrophy is severe and early onset, in cases of syndromic. And systemic investigation, as I already mentioned, when there is a syndromic association, you need to look for accordingly whether the audiogram has to be done, or an ultrasound abdomen, and then endocrine profile, then metabolic abnormalities, the biochemical test related to that, cardiac evaluations, all these things depending upon the systemic involvement that you anticipate from these cases. And you have to monitor once you have diagnosed what is the rate of progression. So the tools like autofluorescence, then OCT, visual field, and the full stimulus threshold test, all these helps to detect you if there is any progression. So autofluorescence is a very useful tool actually to pick up in one glance whether there is a progression or not. And what you can do for these patients, because now the gene therapy is coming more, but it is not widely available, or it is evolving only. So what are the other options? Like lifestyle modification and counseling is very important, like the protective glasses. Then don't give vitamin A supplements for all these patients, because unless you have a genetic diagnosis, sometimes it may do more harm than good. And one very important thing, the importance of genetic, especially when you pick up these and identify these cases, diagnose early enough, because many a times you come across these patients who has diagnosed with IRDs later and have taken up some profession which, like, after they have took the course, they realize that it is not suitable for them. So that actually helps them to pick up a course and study accordingly to their diagnosis. And don't forget that it is not IRDs, but there can be association with other ocular diseases like cataract. So sometimes, especially in RP patients where in the autosomal dominant, the vision might be less. You get an OCT done, see if the fovea is spared, and if you see a posterior subcapsular cataract, then operate the patient. That will be useful for them. Then they can have choroidal neovascular membranes, cystoid macular edema, which usually in those cases we treated with acetazolamide inhibit drugs like that. And then they can have even retinal detachment. So don't forget to miss those findings if they come with a sudden decrease in vision and macular hole. So this is one of the case with the IRDs with the CNVM. So you treat them with anti-VEGF injection. This is a case of macular hole. So you can take the patient for a macular hole surgery. So to conclude, first you confirm the diagnosis, baseline imaging has to be done, genetic counseling, then whatever you can done for vision preservation, the treatment options available, low vision, and the psychosocial support and follow-up monitoring. So this should be the outline. Thank you.
Thank you, Dr. Divya. That was a quick overview of how we have to approach a patient with IRD. I'm sure there will be doubts, but then as we go more about it, we'll understand it in more.